House in Berkeley, California. And he'll be presenting on the topic for this morning shortly. What we're going to begin by doing is currently all attendees are being muted. And that's specifically for a background noise kind of reduction. And so what we'll do in doing introductions is I'll do what's called a roll call. I'll go down our list of attendees. I'll open up your line so that you can greet people yourself and tell us what county you're from, and if there's anyone else that's joining you this morning in attending the webinar. Some of you are doing the webinar today as a group, some with other mental health board members or with your full mental health board. So we applaud you for doing that and for thinking of the opportunity to do it together so that you can discuss things as we're going through the presentation. So I'm going to begin with Cora Gonzalez, and I've unmuted you. So I'd like to welcome you to the meeting. Okay, and thank you, Cora. Thank you for joining us this morning. I'm going to go ahead and mute you again. And next we have John Pearson, who is joining us, I believe, from Napa County. Good morning, John. Okay, now we're going to mute John again. And next we have Kathy Day, who's joining us. Good morning, Kathy.
I'm sorry, I couldn't. Did you say Kathy Day?
Yes. Good morning.
Yeah, that's me. Hi, I'm here from Sacramento County.
Okay, great. And is anyone joining you today in listening to the webinar?
No, not today.
Okay. All right. Welcome, Kathy.
Thank you.
And next we have Ken Baird. Welcome, Ken.
Good morning. I'm with the Kings County Behavioral Health Advisory Board, and I'm actually doing this from home this morning.
Okay, welcome. And next we have Mary Hoffman. Good morning, Mary. Okay. And next we have Mike Gonzalez. Good morning, Mike. And we know Mike is from Tehama County. Okay, we'll mute him again. And next we have Sally. Sally, good morning. Sally Ragnell. And Sally is from Merced County, I believe.
Yes, good morning. This is Sally Ragonette. I'm from Merced County Mental Health Board.
Great. Welcome, Sally. And next we have Sharon Ross, and Sharon joins us from San Mateo County. Good morning, Sharon.
Good morning, Donna, and everybody else from San Mateo.
And is anyone joining you today from San Mateo?
Not that I know of.
Okay. And next we have Vince Ramos. Vince, are you with us this morning? And would you like to welcome, introduce yourself to folks? Okay.
Did you say Vince Ramos?
Yes, I did. Welcome.
Oh, okay. Because I keep getting this thing saying you're registered as listen only. Well, anyway, good morning, everybody. I'm from Merced County.
Okay, great. Thanks, Vince. Okay, I think we're ready to get started. Let's see if there's anyone else who's joined us. Oh, I see that David Richter has.
Yes.
Introduce yourself.
Say it again.
David, would you like to introduce yourself?
I'm sorry, you'll have to say it one more time.
Would you like to introduce yourself and the county?
Oh, yes. My name is David Reister. I'm on the San Luis Obispo County Mental Health Board.
Wonderful. Thank you, David. Okay, so I think we're ready to get started so that we're being mindful of everybody's time. And so again, this morning we're pleased to have with us Dr. Floyd Brown. As Dr. Brown is doing his presentation this morning, if you have questions that you'd like to ask, we would like you to feel free to use your questions box, which is in the box along the right-hand side of your screen, to enter your question, and that will be directed towards both the organizers, which are myself and Dr. Brown, and we will make sure to either attend to your questions as they're coming up, if it seems time sensitive, or we'll make sure to address it shortly after you send it in. Okay, so I'd like to again introduce Dr. Floyd Brown. Dr. Brown was involved in a project several years ago through Bonita House, in which Bonita House participated in a California Institute of Mental Health pilot project looking at integrated dual diagnosis treatment models and their application in different settings and in different practices. And so, Dr. Brown, I'd like to welcome you this morning and thank you for setting aside the time today to bring this important education to mental health board members across the state.
Thank you, Donna. I'm very pleased to be able to speak with everybody today. Actually, it's really nice to be able to do it from my home. I'm looking at a computer screen and also out the window where it's bright and shiny where I am. So I hope everybody is experiencing good weather. I want to make one disclaimer. I've got a cold today, and if I start to cough, I may put my speakerphone on mute for a minute until that stops, so please bear with me. So hold on, let's see. We've got something going on here. Okay, a little technical help here. This isn't working right. So I'm going to try it one more time.
That looks good, Dr. Brown. We see your full screen.
Okay, yeah, I lost my full screen for some reason. I've got, I don't know. I'm going to use the laptop screen. It's easier. I've got a larger screen here in my office, but it's not working right. So can you see my picture now?
Yes, we can.
Okay. Well, that's how I guess I really look. When I look at pictures of myself, I think of myself, how did that old guy get in my picture? But here I am. So today's objectives, we're going to, by the end of this presentation, hopefully you will understand the benefits of integrated treatment for co-occurring mental health and substance use disorders, that you will understand the elements of the integrated dual diagnosis treatment model, that you'll understand the relationship of evidence-based practice to the emerging recovery movement, and finally understand how mental health boards can assist in the development and evaluation of integrated treatment at the system and program levels. As Donna said, I'm Medical Director of Bonita House Incorporated. Bonita House is a community-based nonprofit agency with headquarters in Oakland, California, with programs in Oakland, and I have no commercial affiliations and won't be representing any products or otherwise other commercial interests. Quick look at Bonita House programs. As Donna mentioned, the CIMH implementation training project in which we participated, some of these programs actually did not exist at that time. The two programs at the top, the Dual Diagnosis Residential Treatment Program and the Supported Independent Living Case Management Program, were the programs that received the training initially. We also have a Creative Wellness Center, which is a 2.5-day socialization program. Newer programs is HOST, Homeless Outreach and Stabilization Team, with offices in downtown Oakland, serving most of Alameda County, specifically reaching out to homeless and previously underserved individuals. We also operate the housing portion of the Choices program, which is an Alameda County-wide program which emphasizes recovery and hopefully moving out of the public mental health system. There's a few definitions, some of which you'll see in this slide and some of which you may hear from time to time as you possibly look further into some of the issues that will be raised today. First of all, when we talk about dual diagnosis in this context, we're talking about co-occurring substance use disorders and mental illness. And I'm using DSM terminology here. In addition, this co-occurring condition is sometimes considered to be co-occurring disorders or co-occurring conditions, depending on preferred language. Basically, we mean the same thing as we mean when we say dual diagnosis. IDDT refers to integrated dual diagnosis treatment. SPMI is an abbreviation for severe or serious and persistent mental illness, and that might include diagnoses such as schizophrenia, bipolar disorder, schizoaffective, very severe major depression, etc. Now these two definitions won't appear in my presentation, but I thought it was useful to present them because there is a distinction between dual diagnosis capable programs and dual diagnosis enhanced programs. We believe that all programs should be at a minimum dual diagnosis capable. That is, capability to assess and provide treatment or referral services to persons living with dual disorders. Enhanced programs are specialty programs with the capacity to serve individuals with more severe issues, and this would include IDDT trained teams. Let's start with a case example with two scenarios. In scenario one, this is an individual, a 20-year-old man who had been using crack cocaine and began hearing very disturbing voices that wouldn't go away. He sought help at a local mental health service because of the disturbing voices. If he went to a traditional mental health clinic, he would be told that his problem was related to drugs, that he could not be given any medication, which he was actually seeking, until he was clean and sober for 3 months. So John, because he was wanting help, went to the local substance abuse treatment center and sought help there. When he was there, he was told he was too psychiatrically ill and told he needed mental health treatment. So if you were John, what would you do? And also a question, have any of you who are in the audience who might be mental health consumers or family members of someone living with a mental illness had any similar experiences? This is all too common an occurrence in mental health systems. And by the way, today I'm going to be talking about mental health services with co-occurring capacity, but some of this could also apply to substance abuse treatment programs who have the capacity to serve mental health clients as well. Okay, so why would we want integrated treatment? Well, here's an illustration. John, in terms of what happened, John had multiple hospitalizations, including a suicide attempt. And we'll talk in a moment about some of the risks and increased risks associated with for persons who are living with both conditions. He was eventually referred to us at Bonita House, and he was assigned to a case manager who helped John find housing and helped John apply for benefits, even though he was not really ready to give up cocaine. He was seen by a psychiatrist, and he was offered medication, which he decided to take, and which helped reduce his voices, although he could not commit to stop using cocaine altogether. And over time, with treatment, both psychosocial and medical, John's drug use diminished, his voices became more manageable. So that's scenario one. In terms of integrated treatment, one of the key features is consumer choice. So what happens if John was not really open to taking medications? So here's some of the things that would have been done. First of all, a safety assessment. This should be done in all cases when working with somebody, especially on intake, but ongoing as well. At that point, the intake coordinator or case manager or psychiatrist or whoever was doing the assessment would determine what John's most pressing concerns are and offer to provide appropriate services based on his needs. So, for example, if John's needs were primarily housing, if that's what he was most interested in, that's initially where the team would start. Continuing services would be offered even if John was not completely ready to take advantage of other such as medication. So refusal to take medications would not be a reason to exclude John from services. In the course of working with John, there might be an effort to provide some education about his treatment options at a clinic such as Bonita House's supported independent living case management program. And there would be some discussion about medications and what it might do and what some of the side effects might be, basically to establish risk and benefit. And this would be done in a stage-wise manner appropriate to where John was at the time. And we'll talk more about stage-wise treatment as we proceed. At Bonita House, we use the integrated dual diagnosis treatment model developed at Dartmouth University by Robert Drake and others. This is considered to be an evidence-based practice by SAMHSA, Substance Abuse and Mental Health Services Agency, a federal agency. And here's a list of the 5 current behavioral health evidence-based practices that SAMHSA has published in toolkits to help systems and programs implement these evidence-based practices. Obviously, we're talking about IDDT today, but all other evidence practices include supportive employment, assertive community treatment, family psychoeducation, and illness management and recovery. And there's a website there where you can find more information. And this is one of my favorite slides because these are actually my 2 favorite sports, football. Of course, here we call soccer, we call football soccer. But it's an example of what happens sometimes when you're using the same terminology in different contexts. IDDT can sort of help to bring together 2 cultures that have traditionally been separate. In the traditional addiction or substance abuse treatment model, on the left side of your screen, you can see some of the features of a traditional substance abuse treatment program. Use of peer counselors is common. People in recovery who have gone through and experienced being addicted, recovering from addiction. There's an emphasis on spiritual recovery, emphasis on self-help, such as AA, NA, and similar organizations. Confrontation and an expectation of sobriety have traditionally been features of addiction treatment. In some cases, the confrontation can be quite harsh, or has been quite harsh. In addition, the treatment providers practice some type of detachment. In other words, the substance abuser needs to take responsibility for his use and then become empowered to change his behavior. Treatment in the traditional mental health system was episodic, and the recovery ideology is usually based on a 12-step model of recovery. Any psychiatric symptoms were seen as secondary to addiction, and I can tell you stories about folks that I've seen who went to 12-step meetings, were told by other members that they really didn't need their medications, and I can remember one particularly severe suicide attempt that someone made after they abruptly stopped taking medication for depression. And one of the features is that relapse results in denial of services. And what that can sometimes even mean is that if you use, you're out immediately on the street. In the mental health treatment setting, it's usually a medical model staffed by professionals based on some type of scientific treatment with an emphasis on medication. Support is paramount, and as compared to the traditional addiction setting, there is more flexibility. Individuals are usually assigned to case management and receive care. In some cases, the expectation is that someone will have a lifetime case manager, and that's one of the things that's changing in the mental health system. Treatment is usually continuous, although I think it's becoming increasingly clear that not everybody needs continuous and ongoing mental health treatment, but that it's not considered to be something that you discontinue at some arbitrary point, such as in a 28-day substance abuse program. The deinstitutionalization ideology has been prominent in traditional mental health treatment, i.e. getting people out of the hospital, keeping them out of the hospital. Sometimes that goal paramount over other things that might improve quality of life or capacity to function. Addiction is has been considered to be secondary to the psychiatric condition. So in other words, you drink because you are depressed. You use cocaine because you're trying to escape from the voices. And if a person has a psychiatric relapse, they typically get more service, which might be delivered in a higher level of care, such as an inpatient setting. But there are now new directions in mental health treatment, and there's a new emerging treatment paradigm, which is influenced by three trends: the recovery model, evidence-based medicine, and integration. The recovery model is strongly and heavily influenced by consumer input. Evidence-based medicine, of course, is based on available research and pretty much follows more of a medical model. And integration is the effort to bring together services as much as possible into one center to improve coordination of care and provide more holistic care. Now, sometimes there are some tensions between the trends, but we believe that programs can both be recovery-oriented and rely on evidence-based technology. When dealing with individuals, complexity is the rule. We typically, and in this presentation, we're going to talk about dual diagnosis as co-occurring mental illness and substance use disorders, but other health issues and psychosocial issues need to be addressed as well. Statistics show that persons living with chronic and severe mental illnesses are at high risk for a variety of chronic medical conditions such as diabetes, heart disease, obesity, tobacco addiction, etc. And on average, it has been widely quoted that individuals living with such conditions statistically have about a 25-year shorter lifespan as compared to individuals without, who are not living with mental illness. Bonita House, in attempting to address this, has developed partnerships with a local FQHC, federally qualified health center, called Lifelong Medical Care, to provide services. At our host program, we're fortunate enough to have the funding to be able to support a 3/4-time physician's assistant from Lifelong who is outstationed at host and who operates as a full member of the host team. At the SIL program, we have a nurse practitioner, primary care nurse practitioner, who comes to the clinic one afternoon a week. And if anybody wants more information on integrated medical care, please let me know or email me, and I'll give my email, well, I'll give it now. It's Floyd, F-L-O-Y-D, at Bonita House, B-O-N-I-T-A-H-O-U-S-E, one word, .org, no capitals. Okay, so how are IDDT mental health programs different? Well, first of all, an IDDT program has an expectation that an individual coming in the door might have a complex combinations of what in the medical field we call comorbidities. That is, situations, conditions, et cetera, that happen at the same time. So as Ken Minkoff, who is a national renowned expert on dual diagnosis treatment, has been widely quoted as saying, dual diagnosis is an expectation. And at any one point, it's estimated that approximately 40 to 60% of individuals living with a chronic severe mental illness will meet criteria for a substance use disorder at some point in their lives. In IDDT programs, staff are trained to assess for the presence of both conditions, and a multidisciplinary treatment team is available to provide services to address all the complex needs, which in addition to drug and alcohol, mental health might include assistance in medical care, might be assistance with housing, might be assistance with employment, might be family treatment, so a number of other things, but we're going to focus today, for simplicity's sake, on the dual diagnosis as we defined at the beginning of the presentation. I mentioned before consumer choice being paramount. An expectation in dual diagnosis programs is that shared decision-making is a very key feature, that individualized and collaborative treatment planning should happen, which will include input from the consumer, from family or significant others, as well as providers. And family input, of course, with the permission of the consumer. IDDT mental health programs practice stage-based treatment. We'll talk about what stage-based treatment is later in the presentation. Unlike traditional mental health programs, which have largely stayed away from or even shunned spirituality, IDDT mental health programs help our consumers with whom we're providing service try to reach their full spiritual potential and don't shy away from referral for self-help groups or to assist in developing self-help groups. Treatment is time unlimited, and that does not necessarily mean lifelong, but it's as long as it's needed. There's no arbitrary cutoff. Medication treatments are not dependent on total abstinence. I presented a couple of times for CIMH and elsewhere on the fact that to a great extent it's safe and ethical and beneficial to provide medication to individuals even though they may not be abstinent from drugs or alcohol. IDDT programs and other programs should practice strength-based approaches and utilize a consumer's strengths in order to help move them down the road towards recovery. All programs should be respectful, non-judgmental, hopeful, and welcoming. This is especially part of the philosophy of IDDT. And like all other programs, IDDT services should be culturally informed, sensitive, and should strive to develop cultural competency. If there's questions about any of the language there, let me know. I deliberately did not limit it to cultural competency because achieving cultural competency is a process that starts with being informed and sensitive. Goals are to reduce harm first and to assist consumers to achieve recovery. So the term harm reduction may be used in this context. Integrated dual diagnosis programs certainly practice harm reduction. The expectation is not that an individual must achieve abstinence, although in many cases that would be the optimal outcome. So then we come to recovery. And one of the difficulties in talking about recovery is that I think everybody kind of knows what it looks like, but no one can really define it well. Former Surgeon General David Satcher wrote in the President's New Freedom Commission on Mental Health report in 2003 that recovery is variously called a process, an outlook, a vision, a guiding principle. There's no single agreed upon definition, nor a single way to measure it, but the overarching message is hope and restoration of a meaningful life, and that is possible despite the presence of serious mental illness. And here's some other quotes that I found. The first from Dr. Daniel Fisher, who is a self-identified consumer of mental health services, who is self-identified as having a serious mental illness, said that believing you can recover is vital to recovery. And so basically that's hope. Mark Reagans from The Village in Long Beach says illnesses don't recover, people do. So one of the things that's changing in terms of the medical model practice is understanding that symptom reduction is not the only goal, and that in fact sometimes people function better even if they're living with certain symptoms, as opposed to aggressively, say, medicating somebody to the point where they're non-functional, but they're no longer experiencing, say, voices. A particular pet peeve of mine in talking with psychiatrists who have not evolved to the point of recognizing that our goal is to improve functioning and well-being. And, well, I won't get on a soapbox about that. This is probably not the right audience.
Excuse me, Dr. Brown?
Hmm?
Yeah,
Yes.
we had a question from one of the participants. I'm wondering if you could give a scenario about a strength-based treatment.
Okay, so a strength-based treatment might include someone who comes in complaining of a particular mental health system. Let's use depression as an example. So someone comes in reporting signs and symptoms that meet the criteria for DSM diagnosis of major depression. A pathology-based approach would be to say, let's look at what problems are happening for this individual, and let's try to correct them. A strength-based approach would be to try to identify, for example, what coping strategies has an individual tried and which ones are working. And let's emphasize those. It might also involve looking at previous capacity to manage their lives and to be able to help an individual understand perhaps certain skills and strengths that they had stopped using. You might use an individual's compassion for others to assist them in identifying ways that they can be helpful, for example, to others in their family or their communities. You might find that an individual is bright and knowledgeable and interested in learning more about management of depression, and you might encourage them by providing reading materials, etc. Does that kind of answer the question? It would be looking for personal skills, strengths, coping abilities that can be utilized to help a person down the road of recovery. Does that answer the question?
I think so. So, and feel free, folks, that as you're listening, if you are the person asking questions, feel free to, send in another question if you need more clarification. So thank you, Dr. Brown.
Okay. And the final quote that I have up here is from Pat Deegan, another individual with a degree, but who's also self-identified as a mental health consumer and is a very well-known recovery advocate. And Pat says that recovery is rediscovering meaning and purpose. It's a process, a way of life, an attitude, and a way of approaching today's challenges. And I think that's a very hopeful kind of statement from someone who has experienced life both as a mental health consumer and as a mental health professional. So the question for the group, because I'm not going to try to redefine recovery, I just get it wrong. How do you define recovery? And by the way, I want to brag a little bit. This is my finest sunset shot that I ever took. So that's a Dr. Brown photo slide. So think about it. Maybe have some discussions amongst yourselves. What is recovery? In substance abuse treatment programs, recovery is usually defined as a process that starts with abstaining from substances, admitting powerlessness, and moving on to identify faults and failings, making amends to other people, and then gradually becoming of service to others. And at the end of that journey, through the 12 steps, for example, a person is considered to be in recovery. But in recovery is seen as a ongoing process, a lifelong process. Mental health recovery definitions that I've seen have ranged everything from outright cure to being able to live a happy and meaningful life. I mentioned cultural competency, and I mentioned that the IDDT model was developed by researchers at Dartmouth, which is located in New Hampshire. Obviously, the demographics of New Hampshire and California are quite different. So CIMH, in the project to which Donna referred earlier, evaluated programs statewide, and among the things they looked at was outcomes for minority clients. For minority clients being served in mixed ethnicity outpatient clinics, there was no evidence that IDDT was less effective. However, in one clinic, which served a large number of monolingual Spanish-speaking individuals, that site had comparatively poorer outcomes. So what this means is that we really need more research, more investigation of the applicability of IDDT across cultures, particularly for individuals who may be predominantly monolingual and who are not acculturated into American culture to the extent that people who have been here for whose families have been here for generations might be. I think this is an area where we need more research. Also in the report, they did not identify the modifications that were attempted at that particular clinic in any specificity. So I'm not sure exactly what they tried. But in any event, they found, the researchers from CIMH found that the outcomes were not as good. Talk a little bit about consumer employment in IDDT programs. In the substance abuse field, treatment field, as I mentioned, use of peer counselors has been traditional, but they're under pressure now because of federal financing and regulations to include more licensure or certification, and that is an area of controversy in substance abuse treatment programs at this point. I believe that IDDT-based programs do represent an opportunity to integrate consumers and family members as full team members. At the host program, We have one slot that is dedicated to a self-identified consumer of mental health services who functions as a case manager. Other programs have used peers or family members as peer counselors without the widespread generalist duties of a case manager. Some issues to consider are, first of all, what is the role? So if you're including a consumer or a family member on the team, is their role confined to peer counseling, to peer family counseling as a specialist, which could be very valuable, or as a generalist, that is basically performing the full range of services that a mental health case manager might perform, such as outreach, assessment, counseling, etc. Another thing to consider is what training is necessary, and what experience might be considered in evaluating somebody that you might hire excuse me, into this kind of position. Then looking at the value of lived experience versus licensure, which may have some implications for billing and reimbursement for programs. And then looking at documentation requirements. One of the issues that came up at HOST with a previous peer who was hired as a case manager were some issues around understanding how to document, what to document, what not to document, etc., which required a significant amount of supervision and retraining. All right, so let me take a sip of water for just a second. Okay, so co-occurring disorders are common, as I mentioned earlier in the talk, estimated to between 40 to 60% lifetime prevalence. So that doesn't necessarily mean ongoing substance use disorders. It might mean episodic substance use. And that contrasts to the lifetime prevalence of substance abuse in the general community, estimated to be about 17%. You'll notice from the reference there that this data is pretty old, but the ECA, Economic Catchment Area Study, is still the largest study ever done on epidemiology of behavioral health issues in the United States. I'm going to show a couple of slides to illustrate some findings and a little bit of clarification. In the legend in slide 1, I have legend MDD, major depressive disorder, and the second slide, MD, major depression, and that basically refers to the same condition. So looking at the bar graph here, you can see that people with significant mental health issues commonly abuse at one point in their life substances. Interestingly enough, people with some of the more, what we generally consider one of the more serious mental illnesses, schizophrenia and bipolar disorder, have very high rates of substance use as compared to the general population, which is on the right-hand bar. And this looks at use of drugs versus alcohol. So any drug use, any alcohol use disorder, and you can see that across pretty much the range of conditions that are identified in the graph, that alcohol was the drug of choice at the time of the study, and I think that would still be true. Interestingly enough, in major depression, the graph shows a slight increase of drug use, but basically I think that can be read as roughly equivalent. Okay, so I mentioned that having a co-occurring disorder, having a dual diagnosis, is associated with adverse outcomes. And here's some of the ones that are listed: hospitalizations and psychiatric relapse, risk of incarceration, risk of violence. Individuals with mental illness on average do not commit violent acts more frequently and possibly even less frequently than people in the general population. But when you add the disinhibiting effects of drugs and alcohol, the risk of violence perpetrated by someone living with a mental illness increases. A lifestyle of drug and alcohol use increases exposure to some severe chronic infections such as HIV and hepatitis. It is associated with unemployment and an increased risk of living in poverty. That it has a negative impact on family and interpersonal relationships. An increased risk of either perpetrating domestic violence or in many, many cases being victim of domestic violence. A major issue in our work with folks at Bonita House is often history of very traumatic domestic violence situations, and a common co-occurring condition among many of our clients is post-traumatic stress disorder, or if not meeting full criteria for that, certainly significant trauma-related issues, which is a whole lecture in and of itself. Health risks, including early death, and increased risk of suicide, which I talked about when I presented John's slide. So how do you treat dual conditions? Well, the traditional model was sequential. In the sequential model, a person would go to a mental health clinic or substance abuse clinic seeking assistance. That individual would be told, go get your problem dealt with over across the street at the other clinic, and then when they're done treating you successfully, come back and we can treat you for the other. Parallel treatment is better, and actually in research shows some positive outcomes. Parallel treatment is when a person is simultaneously receiving services from two different treatment teams, one a mental health team, the other a substance use disorder treatment team. And that can work, but it requires a lot more communication, or it requires the consumer to really try to integrate the two programs on his or her own. The integrated model, which we describe today as IDDT, has been shown in research to improve substance abuse outcomes. And as I mentioned, it is considered an evidence-based practice. And once again, the toolkit for IDDT, along with the other evidence-based practices, is available on the SAMHSA website. Let's take a look at some advantages, and rather some disadvantages of the sequential and parallel models. In the sequential model, for example, if you are someone who is entering treatment for, say, schizophrenia or symptoms of psychosis, and you're also using drugs or alcohol, most likely that untreated drug or alcohol program is going to worsen the psychiatric condition and certainly adversely affect the outcome. It's sometimes not clear which disorder should be treated first, and in fact treatment was often denied. And it's unclear when one treatment has been successful and so that the other treatment can begin. The consumer in the sequential model may seek services at the entry point clinic, would be in the SUD system or the mental health system, but would not always be referred on for treatment and just be told that they were not appropriate for services at the clinic. In the parallel model, the treatments are still not integrated, And one of the risks is that the providers will not communicate or won't communicate well, and so the burden of integration falls on the consumer. There may be funding and eligibility barriers to accessing both treatments. Sometimes the consumer has to deal with incompatible treatment philosophies. So, for example, a substance abuse counselor telling a person that they don't need psychiatric treatment when actually they may well get worse without psychiatric care. And when I say psychiatric, I'm speaking as a psychiatrist. I'm also talking about mental health and behavioral health care in general. So please assist me in making that translation into your own mind, and I'll try to minimize my use of that kind of jargon. Finally, there's no one that has the final responsibility, and so a consumer can sort of slip through the cracks and not get the treatment they need. There can be a lack of common language and methodology. So basically, the parallel and sequential models have some flaws, which we try to address in integrated dual diagnosis treatment. When services are delivered by one organization, the administrative barriers are eliminated. In our programs at Bonita House, there is a, and I'll talk about the multidisciplinary outpatient case management programs in particular. Services are integrated and delivered by the same team. So there's no coordination between providers required, and there will be frequent contacts between multidisciplinary team members. Sometimes may have different responsibilities for different individuals, but that comes together as the team discusses the individuals that they're serving, what their current issues are, what progress has been made, and what still needs to be done. Both disorders are considered primary and are treated concurrently at the same time. Sometimes there are conflicts, philosophical conflicts between staff that come from mental health training background and staff that come from a substance abuse counseling background. But one of the things that we've seen historically at Bonita House and that other programs see is gradually the conflict over philosophical differences is minimized and shared perspectives evolve. Okay, briefly, history of dual diagnosis at Bonita House. Bonita House has been around since 1971. We get our name from our original program, which is the dual diagnosis residential treatment program, which is located in North Berkeley. That program and the agency became dedicated to serving individuals with co-occurring disorders in 1991. In 2004 to 2007, we participated in the IDDT training project conducted by CIMH, and we still participate in Alameda County's countywide co-occurring conditions initiative, which has now moved from a training and implementation phase into being subsumed under quality improvement department, and has been able to do some important things, for example, with contract language. All programs in Alameda County now are supposed to identify as part of their contracts what efforts they're currently making in the area of co-occurring disorders. It's not yet a requirement, but just initially trying to determine what's happening at different programs who had previously been offered training services through a partnership with trainers Ken Minkoff and Christy Klein. All right, to review IDDT basics. The priority population is the population identified as severe are serious and persistent mentally ill, but others may benefit as well. So people with what are considered to be less serious conditions may also benefit from the type of integrated care that occurs. And this is particularly important in substance abuse treatment programs who are adopting co-occurring disorders capability, is that in some cases very severe psychiatric illness may be beyond their capacity to manage, whereas, more so rather less severe conditions might be manageable in one site at a substance abuse clinic. The evidence-based model is research supported, and evidence shows that it results in improved clinical outcomes. One multidisciplinary team provides mental health and substance abuse services, and that the coordination of treatment incorporates consumers, families, significant others, as well as providers. Take another little break for some water. So talk a little bit about Fidelity. Fidelity refers to how many elements of a particular evidence-based practice a program is able to achieve. So programs with the most similarity to evidence-based practices have the best outcomes. In addition, IDDT, besides integrated dual diagnosis treatment, has elements of some of the other evidence-based practices. So if a program incorporates IDDT, they are getting closer to fidelity in some of the other evidence-based practices. And even if full fidelity isn't achieved, services can be improved. CIMH used a fidelity scale in their SAMHSA-funded study and used it as a pre- and post-assessment, and actually ongoing assessment of programs during the 3-year trial. And it assesses fidelity across 13 domains using a 5-point scale, which measures, with 5 being the highest level of fidelity. Here are some of the domains in the fidelity scale. I'm not going to go over them all at this point. They're there in your slide deck, and you can review them. And we're going to talk about some of the practice elements that relate to these fidelity scales. Please note that CIMH actually added a section on integrated assessment and treatment planning, which I think is an important aspect of a well-functioning IDDT program. So here's some of the practice components. I'm not going to read this list because we're going to talk about them individually. You can find more information from the Ohio Substance Abuse and Mental Illness Co-occurring Center of Excellence, which is hosted at the website run by Case Western Reserve University, and the URL for that is down at the bottom on the right. Okay, so first of all, what do we mean by multidisciplinary team? It includes professionals and paraprofessional clinicians with previous training or background in mental health or substance abuse treatment. At Bonita House, we hire individuals and we try to maintain some type of a balance between individuals who have been trained or even licensed as mental health professionals and individuals who may come in with life experience, some counseling training, some of whom are self-identified as consumers, some of whom are self-identified as in recovery. So it may include licensed professionals, unlicensed clinicians, and persons with lived experience who may be either licensed or unlicensed. At Bonita House, everybody's cross-trained in the IDDT model. In some programs, a substance abuse specialist may be hired to work collaboratively with the team, and this provides an excellent opportunity for some programs for role modeling, for assistance in developing assessment tools, for assistance in providing appropriate care and treatment. Vocational and housing specialists ideally would be integrated into a team, but this mostly occurs in FSP programs around the state. FSP, full service partnerships, are funded by Mental Health Services Act money, the California Millionaires Tax, which was Prop 63, and in FSP programs there may also be integration of primary care. As I mentioned, our host program, which is an FSP, includes primary care, but also vocational and housing specialists on the team. So I talked about stage-wise treatment. Here's kind of what we mean. First of all, stage-wise treatment is based on a theory first proposed by researchers Petraska and De Clemente, who I believe were at the University of Rhode Island at the time. And they developed an understanding of how people change based on several levels of readiness to change. In the first, pre-contemplation, an individual does not identify a problem, and is thinking of, and is not ready to change, not thinking about changing. At the contemplation level, perhaps there's a problem, and maybe I might like to change. In preparation, it's like, yeah, there's a problem here. I need to change it. What can I do to get ready for that? In action, you're actually beginning to initiate an action plan. You're taking steps. And in maintenance, you continue to follow a plan in order to avoid relapsing or resuming the behavior. And this can be any type of behavior. In some of the training that I had on stages of change and later motivational interviewing, which we'll come up with, people identified everything from losing weight to going to the gym to stop smoking, whatnot. And so it is not limited to psychiatric or substance abuse issues. Now, one thing to say is that an individual can be at different stages of readiness to change for different problems. So a person might come in ready to work on a substance-related problem and enter fully prepared to make a change, whereas they may not acknowledge having a mental health issue and are not prepared to take any efforts in order to really pursue treatment for that condition, even though objective observers may identify signs and symptoms of mental illness. In addition, treatment occurs in stages as well. And the treatment stages are, first of all, engagement, in which possibly through outreach, a relationship begins to form, a treatment alliance begins to form. In the second level, persuasion. The counselor helps the client to begin to develop motivation to participate in interventions that are recovery-oriented. So that might occur as a result of providing an individual with information or education. It might occur by helping an individual examine the costs and benefits of continuing a certain behavior. And those are just some examples off the cuff. In active treatment, the client is assisted in acquiring skills and assisted in identifying a support system for managing their illness and pursuing their goals. So again, treatment is considered to be based on the client's self-identified goals and readiness to work on that particular issue. In maintenance, strategies are developed for maintaining recovery and continuing progress towards recovery. Access to comprehensive services. Residential services may include housing referrals. Some programs actually, for example, Bonita House owns several units of housing, and we have at the host program master lease contracts in various apartments around Alameda County to help assist people. Host is a housing first program, which means that individuals are assisted in obtaining housing as soon as that individual is ready to accept that kind of help. And that can occur before any other treatment occurs. In addition, it might include access to residential treatment. As I mentioned, Bonita House has its own residential treatment program. Access to supported employment. In Alameda County, the Alameda County Vocational Program is the primary resource for programs that do not have in-house employment specialists. Family psychoeducation, family outreach, those kinds of efforts are very important. And illness management and recovery, which is interventions to help a person learn to manage their illness, whatever it may be, to identify recovery goals and make informed treatment decisions. Access to comprehensive services. Now this is a difficult one to have good fidelity with, if that's the proper way to phrase that. Assertive community treatment is an evidence-based practice model that has a very low consumer to case manager or professional staff person's caseload. So traditionally, assertive community programs have 24/7 wraparound services, and most of the services occur in the field. Intensive case management is similar with the less of the available services of a full-scale ACT team. And these low caseloads are very difficult to achieve in programs that are not specifically funded as ACT programs. Because of the large numbers of individuals in the public mental health system in our counties and around the state, many programs will not be able to achieve this type of ratio. Time unlimited services we've talked a little bit about, and that's just basically treatment is available as long as it's needed with an intensity modified according to what's needed at the time and how far along the individual is in recovery. Outreach is an important factor, and assertive outreach, not necessarily case finding, that depends on the structure of the mental health system. In Alameda County, access to services is centralized, and individuals seeking services are initially assessed at this centralized service and then referred out to agencies in the community. A lot of outreach can be necessary in the engagement stage when an individual is not truly allied with the treatment team, maybe still having a lot of ambivalence about whether they have an issue or whether they want services for the issue. So community engagement is really something that's ongoing. At our SIL team, we actually divided our case managers into an early engagement team consisting of 2 case managers who have lower caseloads, who actively engage with individuals who are being referred, whether it be in their homes, in the hospitals, if the referral is coming from the inpatient, from one of the inpatient services, and even in forensic services, jails, and well, mainly jails. We rarely have outreach to prisons. So as a result of that, then the recovery team has is for people that are engaged in services, have identified goals and are working on goals. They have larger caseloads. Their work is still often field-based, but more office-based services than the early engagement team. That's just one example of how we modified our services according to what we felt of our clients. Here's some of the issues that might be areas where you can assist a consumer, and that can often be best done in the community, looking at assistance with housing, with benefits, providing crisis intervention services, assisting them with obtaining medical care, and assisting them with legal issues. I think I might have mentioned motivational interviewing. Motivational interviewing is a model that was developed by William Miller and Stephen Rolnick. Dr. Miller is a psychologist emeritus at the University of New Mexico, and he's sort of the grand guru of motivational interviewing. Steve Rolnick is an MD from the United Kingdom. And together they developed a collaborative, non-judgmental, consumer-centered approach which is grounded in an attitude of respect. It focuses on building rapport and identifying, examining, and resolving ambivalence about behavior change. And what I mean by ambivalence is, you could sort of say, being of two minds. Maybe I'd like to change, but maybe I wouldn't. Maybe I can change, but maybe I can't. And the assumption under the motivational interviewing theory is that ambivalence about change is normal, and that people sort of have to work through their ambivalence before they're able to move on to another stage of treatment.
Dr. Brown, can I interrupt for a quick second?
Sure.
This is Dr. Matthews. Yeah, we had a comment by someone, and I thought it might be relevant to kind of share it right now before we continue on. And when you were mentioning about the stages of change or stages of relationship, that this person was mentioning that in psychiatric nursing theory, that there's actually psychiatric nursing theory includes a kind of a pre-initiation where nurses look at their own issues regarding particular client situations as well, and that there's a lot of attention to engagement, motivation, and goal setting as well. So, you know, I just thought that that might be an important kind of nuance to bring out, is that other professions are also looking at these types of stages of change as well.
Yeah, I agree that excuse me, it's important for people to have I think a basic understanding of the fact that if you deliver services to individuals that are not matched to their particular stage of readiness, then that treatment has a high likelihood of failing. So, for example, one of the problems that might come up is if an individual is in that pre-contemplation, early engagement stage of treatment and change, offering, say, an abstinence-based program may be the entirely wrong thing to do. Someone who's saying, I don't have a substance abuse problem, and even saying, well, I think you should go to an AA meeting, you know, that may be the wrong thing to do. And one of the things that's a key with motivational interviewing is that you try to match your interventions. If you and that if you end up arguing with the client about why they should change, then you've made an error. That if a suggestion is made or an intervention is made that really is premature and you get a lot of resistance, you just sort of roll with that resistance. You don't continue to engage in some type of an argument that'll just drive a wedge between you and the consumer that you're working with. I think this is widely being adapted by various professional groups. Many people in the substance abuse treatment field were using motivational interviewing before it started to come into play in mental health treatment. And I'm glad to hear that in psychiatric nursing training that this is being done. I actually am on the affiliate faculty at Samuel Merritt University, which is a organization that trains nurses, nurse practitioners, and physician assistants. So I get interns, family nurse practitioner interns that spend a term with me. And I have noticed that all of them that are coming in to work with me are familiar with the concepts of stage-wise treatment, motivational interviewing, and stages of change.
Could you repeat the name of that organization again?
The Samuel Merritt University?
Yeah, just one of our callers was, or participants was asking.
Yeah, Samuel Merritt University is located in Oakland on the campus of the Altabate Summit Medical School at the Summit campus. And they've been around for years, and they have both bachelor's in nursing programs, advanced degree programs for nurses, and they also have physician's assistant training at Samuel Merritt. So it's a very good institution, and I enjoy very much working with the students that get placed with me. Been some really good folks, and some of whom I've actually recruited into going into psychiatric nursing as and psychiatric nurse practitioner programs. So anyway, that's a kind of a wide digression. Let me get back to the topic.
Thank you.
Substance abuse counseling services includes recognizing and managing triggers. Triggers are internal or external events that may cause an individual to crave or to use substances. Relapse prevention planning is something that happens when an individual is further advanced in recovery and is working not to resume their previous behavior. So an example would be someone who's a few weeks clean and sober, still tempted, still living in an environment where drugs and alcohol are ubiquitous and may be offered to them, developing, say, refusal skills, skills in identifying environments that they should stay out of, people that they should avoid, etc. All of those. And also relapse prevention plan might involve when you feel depressed or anxious, who can you call, what do you do, what skills can you incorporate in order to avoid relapsing in response to negative feelings inside or to negative thoughts. Challenging beliefs might include, for example, the belief that, without using drugs or alcohol, I wouldn't really be able to manage my condition. Or the only way I can control the voices is if I drink. So some of these beliefs you can challenge, again, using good counseling skills and working with someone with dual diagnosis in particular, avoiding harsh encounter methods. Skills training to deal with symptoms and negative mood states, I sort of mentioned that as part of relapse prevention planning. Okay, group dual disorder treatment kind of speaks for itself what that is. A group that's designed to address both co-occurring problems. Family psychoeducation, again with permission from the consumer, family and or significant members of one's support system are engaged in some efforts to provide education, to improve their own coping skills, and to promote collaboration with the treatment team. And I consider the consumer to be part of that treatment team. Participation in alcohol or drug self-help groups. There's a number of self-help groups out there. The most commonly known are the 12-step programs such as AA and NA. There's also Rational Recovery, which is more sectarian in its language. And Dual Recovery Anonymous is a program that has modified the 12 steps to include recovery from mental health issues as well as substance use issues. As I mentioned, referral to self-help groups is sometimes not the intervention that should be done at early stages of engagement and in pre-contemplation. But when it's appropriate, facilitating participation in self-help has been found to be very useful. When I've spoken about referring mental health consumers to 12-step groups, some of the feedback I've gotten from clinicians has been, well, I referred, my client went to an AA meeting, and they were very unfriendly to him and sort of ignored him when he mentioned he had a mental health problem, and it just wasn't a very welcoming atmosphere. And what we found at Bonita House is that there are meetings in the community where people do feel comfortable and do find themselves accepted. Just yesterday, I met with one of my long-term clients, a woman diagnosed with schizophrenia who hears voices every day despite medication. And she is 13 years clean and sober, sponsors other individuals in treatment, and is broadly accepted in the 12-step community and has found it very beneficial. So I think there are meetings out there in smaller communities that might be difficult to find, in which case you might want to consider setting up a Dual Recovery Anonymous group to be held at the program. The 12-step AA and NA have hospital and institutions committees, which can sometimes help assist you to set up a 12-step program, 12-step meeting at your clinic site. Pharmacological treatment, which of course is of particular interest to me as a psychiatrist. Psychiatrists and widely and increasingly we're now using mid-level practitioners, which are basically nurse practitioners and physician's assistants who are trained in integrated dual diagnosis principles. And these are the 5 principles that are identified on the Fidelity scale. One of them, prescribing medications despite active use, working closely with teams and consumers. In some mental health settings, the psychiatrist is sort of isolated in an office, just sees people for medications, has minimal contact with the team, minimal input into the treatment plan, and in order to fully adopt IDDT, the psychiatrist needs to be fully a part of the team, be part of the treatment planning process, regularly meet with all members of the team. Let's see, where are we? Focusing on increasing medication adherence. Basically, for individuals with severe and persistent mental illness, in general, adherence with medications leads to better outcomes. There are, of course, consumers who do not accept or need medications. Some people may use medications at some point in their lives and not need medications at other points in their lives. Other people will need chronic ongoing medication management in order to reduce symptoms and improve functioning. So there's a range, a spectrum. Avoiding and minimizing the use of addictive medications. So, for example, commonly benzodiazepine medications, these are anti-anxiety medicines such as Ativan, Valium, Xanax, etc. Can be risky to use both because they are in and of themselves habit-forming and because in combination with some other substances such as alcohol, you may have significant adverse and even fatal events. Also, people can divert and sell some of these controlled substances. So we try not to use them except where we can well document that the risk of prescribing them is significantly less than the benefit that might be derived from taking them. And also using medications that may reduce addictive behavior. There are anti-craving medications out there for alcohol and opiates in particular. There is some evidence that suggests that some of the newer antipsychotics, particularly clozapine, which is not really new, but which is one of the newer generation antipsychotics, may have beneficial effects on reducing substance abuse. The evidence is not the strongest, but until better evidence comes along, psychiatrists will try to use medications that might have the potential for reducing drug and alcohol use. Okay, interventions to promote health in areas such as physical health, the social effects of psychiatric or mental health issues and substance use issues. Interventions to improve a person's capacity to provide care for themselves and increase their capacity for independent functioning. And interventions to reduce the unsafe use of substances. So this might be harm reduction approaches. It might be things like needle exchanges to reduce the risk of contacting HIV or hepatitis C, for example. It might be, okay, if you're going to use drugs, don't go into that neighborhood where you keep getting mugged because it's not safe. So if you're going to use drugs, use elsewhere, for example. So harm reduction techniques in essence. Secondary interventions for treatment non-responders. Basically, if someone is not benefiting from the treatment in the outpatient IDDT team, higher level of service might be indicated. In extreme instances, this might be hospitalization. It might be referral to more intensive treatment such as case management or to an intensive day treatment program as an adjunct to treatment for individuals who are not having an adequate response. Okay, let me take a quick second to drink a little water. And Donna, how are we with time here?
We are doing fine for time, so I think that we're moving along pretty effectively. So okay. I'm tracking questions, and just so folks know, if you do still have questions, you can ask them. What I'll try to do, though, is be mindful of our time frame as we're going as to how long we spend on questions.
Okay, this is a slide entitled Adapting IDDT. I probably really meant adopting IDDT, but perhaps both words might be relevant. We'll see how in a minute. So IDDT programs actually have some goals for transforming service systems, organizations, as well as individual clinical practices. At the systems level, policies and procedures, fiscal support, development and support resources, and a functioning QA/QI process are important. And we're going to talk in a moment about possible roles for mental health boards in examining systems and helping to identify barriers to the implementation of co-occurring care. Organizations have to deal, first of all, with leadership. There has to be a strong leadership process that develops an organizational an organizational philosophy that supports integrated care. Organizations have to be willing to allocate resources for training, implementation, and supervision, and ideally, monitoring and evaluation would occur on a regular basis. In terms of individual clinical practice, there's a process. Just as I described stages of change, there are stages of change issues for individual clinicians who first of all need to be assisted in buying into the idea that changing the way they practice will have benefits for improved patient care outcomes. Secondly, then training and supervision needs to be applied, and that training and supervision is something that we initially got at Bonita House via the CIMH project to which we referred previously. And then attaining these new skills and maintaining them becomes a challenge for an individual clinician, and organizations need to support the acquisition and maintenance of skills. Let's talk a little bit about program evaluation. This is a quote from the from section 5604.2 relating to mental health boards. Some of the responsibilities including reviewing and evaluating the community's mental health needs, services, facilities, and special problems, and advising local governing bodies as to any aspect of the local mental health program. So I understand that CIMH is providing assistance to mental health boards to develop some of these capacities, and hopefully the following suggestions and thoughts might be helpful. So in thinking about taking on that program evaluation effort, I suggest that maybe a good place to start is with the systems. And at a county level, that would be the local mental health agency, at the local mental health director's office, the local behavioral health director's office, depending on what it's called in your area, and try to identify what, if any, efforts are being made to develop comprehensive integrated services in your local areas. And beginning with the assessment of those systems, looking at some of the items that I showed in a previous slide about policies and procedures, fiscal policies, support resources, and QA/QI policies, reviewing data collected by the local mental health department, and then assisting the local mental health departments to assess the needs, set priorities, and plan for program development. In terms of looking at programs and organizations, one suggestion that I have is that you establish a goodwill relationship with programs prior to coming in to do an evaluation. You kind of get to know them, talk with the executive management, possibly with the management team, talking about what the goals of a program evaluation might be. Programs are going to be a lot less defensive if they know that the purpose is to help them improve quality of services as opposed to being dinged for not following a guideline. However, if problems are observed, those should be reported to the mental health department. So those are some of my ideas. Some of you might have others, and if we have time, I'd be interested in hearing what some of your thoughts are. In terms of evaluating systems change, starting with the leadership from the top down through middle management levels, looking at policies and procedures that support the adoption of co-occurring disorder treatment, including IDDT. One of the things that programs have said a barrier to implementing integrated substance abuse services into their mental health services is we won't get paid for it. Well, that's not actually true. As long as the primary problem is linked to a mental health diagnosis and treatment is linked to reducing the impact of substance abuse on the primary condition. Medical justification can be documented, and payment will be made. Reimbursement will occur. QA/QI systems, Alameda County is embarking now on its next level to create QA/QI systems that support the evaluation and ongoing development of co-occurring systems, programs rather. Okay, one of the ways that you might evaluate an organization is by looking at some of the IDDT elements, we'll go over them individually fairly quickly. In addition, since I made this presentation, I came across a evaluation instrument that's developed by the Dartmouth Psychiatric Research Group, and it is called DDCMHT version 3.2, and I'll email that reference to Donna. Some of you might want to look at that. It's something that I don't have any familiarity with, but it looks pretty comprehensive and might be useful as a template. So Donna, I'll email that information to you so that people can get it if they're interested in checking that out.
Sounds good.
Okay, so in looking at program philosophy, when you come into a program, first of all, you want to see, is there a clearly articulated and shared philosophy that's consistent with IDDT? Starting with executive leadership, through senior management, through middle management if there's if an organization is large enough, through clinicians, but that also the philosophy is understood and shared by consumers and family members, and that brochures and written materials reflect the program philosophy. Assuring that all individuals who are entering the service undergo some type of screening or assessment process, which is consistent with the IDDT model. That could be a standardized screening instrument. It might be a standardized process of what kinds of questions are asked to identify individuals who have co-occurring disorders or may be at risk of having co-occurring disorders. Penetration, described as the number of clients in a program receiving the treatment divided by the number of clients eligible. In other words, it's sort of a look to see if only a small group of people who need the services are getting services, or if a larger percentage of people who are eligible for that kind of service are receiving treatment. In terms of looking at treatment plans, goals, objectives, services, and interventions, and the intensity should be unique to the individual consumer. In other words, there should not be cookie-cutter treatment plans that say basically the same thing for each consumer. And in addition to individualized treatment planning, the progress notes should reflect the focus on these unique and specific goals and reflect a collaborative development. And that in reviewing individualized treatment, the treatment interventions are stage appropriate. In terms of training, there should be a process in an agency by which new staff receive some training in IDD practices, and that knowledge and practice gaps are identified, and that additional training would be provided either through a formal training process or through ongoing supervision. And existing staff should get regular refresher trainings so that skills are not lost or become eroded. Supervision is very impossible, and so program managers should provide weekly individual or group supervision, assuming that those program managers have been trained in the IDDT model. There should be some process for monitoring the progress of IDDT implementation, and hopefully data can be developed to provide feedback and improve the program. Now, data acquisition is challenging for small agencies. We'll talk a little bit about that when we talk about the Bonita House experience. Outcome monitoring, again, developing IDDT outcome monitoring and collecting that data in an agency without an evaluation department can be challenging, but certain data can be identified and is required by most systems. So at the very least, looking at those outcomes and possibly helping individuals individual programs identify other areas for identifying outcomes. Quality assurance plan to review the fidelity to the model, to assess the progress and implementation, and to make recommendations to the organization for service improvements. In one of the goals of transforming the QA/QI process in Alameda County is to help programs across the board be able to do this more effectively. Consumer client choice, you should look to see that a range of choices are offered, that practitioners abide by client preferences, except when doing so would result in risk or harm. So in other words, if I have someone that comes in and says, Doc, you know, I really can't sleep at night, and I find that Vicodin is really the only thing that helps me sleep. I'm going to say, no, sorry, I'm not able to provide you with Vicodin for that. That's not what Vicodin is for. However, I can talk to you about other ways that I might be able to assist you with sleeping, as an example. Another might be if someone is saying, I choose to, I'm going to take this medicine, but I'm going to choose to take all of it and commit suicide. In that case, obviously there are issues that you need to address before providing medication becomes the goal. Evaluating clinical practice change, more than likely, this is not an area that mental health boards will get directly into, and that is evaluating individual clinicians. But understanding some of the ways that clinicians can be evaluated is, first of all, what is their knowledge of substances of abuse? What are they? What do they do? What happens when you become addicted? What happens when you go through withdrawal? What confounding symptoms might they exhibit? For example, some drugs of abuse can produce symptoms that closely mimic psychiatric symptoms that are not due to substance abuse. And the ability to assess substance abuse and mental illness is important. All staff members should be capable of doing those kinds of, depending on their level of training, those assessments can be more or less comprehensive. Motivational counseling skills and stage-based treatment interventions are skills that that clinicians should have, and they should have the capacity to integrate substance abuse counseling skills along with mental health counseling. Okay, so now we're going to talk a little bit about Bonita House's experience. And just as I run a group weekly at the residential treatment program, and one of the things that I ask everybody every week is, what successes have you had in the last week that you'd like to share with the group? And sometimes a resident of the program will say, I can't think of any successes. And then I'll ask other members of the group to identify successes they have observed. And if you look hard, you can find in almost everybody's life some area of success that they've had. And for example, if you've had one day clean and sober, that's a success. in terms of successes that you guys is that we were successful in training all staff in the use of stages of change and stages of treatment concepts. We were also able to train everybody in motivational interviewing, and we've had trainings in these two areas even after the CIMH project was completed. We have been able to improve our assessment process. I will talk about a roadblock that happened in just a moment. Our treatment planning certainly has become more collaborative and more client-centered. One of the things about Bonita House that I think is very strong is that we have a distinct agency culture and philosophy, and we've been able to maintain that in part because we have been able to retain senior and middle management leadership to a great degree. While we have had turnover of many of the people who originally received training, the senior management and the middle management supervision has remained relatively consistent. And so transmitting that agency culture from the program leadership has been eased. So what are about challenges? First of all, it takes a lot of time and effort to train new staff once the CIMH sponsored training ended. And so finding ways to orient new staff, finding ways to train them up is important. That process actually begins at the interview stage when we ask people certain questions about their experiences and their facility in using certain of the important clinical skills that are necessary for IDDT. I mentioned assessment was a challenge. We created something called the FAI, Functional Assessment Instrument, which was very comprehensive, was intended to be a living document that was added to and updated ongoingly. What we found is that it was very difficult for staff to use, and it sort of devolved into, instead of doing an assessment in a sort of more conversational style, it devolved into just asking question 1, followed by question 2, followed by question 3, etc. And so because it was so time-consuming and so difficult to use, we did end up having to modify that. Another challenge is maybe what you might call mission creep. That's something where people lose skills, and that is particularly a problem when you get staff turnover, which happens more frequently in entry-level positions and frontline staff positions because of the realities of salary structures for small nonprofit agencies. I mentioned that monitoring, program evaluation, and outcome measures are challenged beyond sort of basic things like basic utilization, hospital utilization, etc. Because smaller agencies lack the resources to have a research and evaluation division. Other challenges, we found that we had difficulty recruiting and retaining consumers for group interventions. The startup to a group, very intensive. Having people return for groups on a consistent basis, very difficult, even when we offered things like food at each group. One particularly useful outcome was we had one of our case managers who was self-identified as a recovering person who had excellent engagement and incorporated into his group some fun activities such as taking some of the group members to an A's game, going on an outing, etc., in addition to the regular group work. So that was one of the more successful efforts. Also, likewise, we've had difficulty recruiting and retaining family members for groups. We've been more successful at the residential program, where their loved ones and family members who are being treated there. We found that families in that setting seem to be more motivated. Some of the issues that also come up are flexibility on when the group is to be held. It needs to be held often at times when family members are able to attend, so they don't have to miss work, which means weekends and evenings, which can become a human resources issue in terms of complying with California laws on that. And then I kind of mentioned that it's difficult to maintain optimal caseloads with the large numbers of referrals coming from centralized access. So here's some of the lessons we learned. First of all, the fact that we were already a co-occurring agency meant that we were already fairly closely allied with IDDT principles in terms of our philosophy. We learned that newly learned skills require ongoing supervision and training in order to not have clinicians sort of lose those skills or cease practicing them. Certainly staff turnover is a challenge, needing to orient and hire and train new hires, making sure that all team members share similar philosophies and have a background in basic skills. We were not really able to implicate the intensity of training that we got from CIMH, so as new people come on, the challenge is to give them enough information in the orientation phase and then supplement that with ongoing periodic trainings and supervision. As in any agency, there are competing training priorities, and so there are other areas that we also address, including trauma-related care, confidentiality requirements, suicide assessments, any number of different trainings that need to happen in order to maintain skills. Mentioned that fiscal realities may intrude, but services can be improved by implementing as much of the IDDT model as possible. And I mentioned that use of comprehensive assessment instruments can sometimes be challenging, and you have to balance out the comprehensiveness with the ease of use and make sure that it is useful and can be administered appropriately. So I think we have a little time left for questions, if there are any comments or other input from the audience.
Yeah, Dr. Brown, this is Donna Matthews again. I want to let you know that there were a couple of comments, and looking back to some of the discussion you had about strategies used at Bonita House, and there's a question about pain management and wondering how chronic pain challenges for folks are managed or how folks are worked with and supported in dealing with their chronic pain when they have substance abuse issues and that sort of thing. So wondering whether or not you can share it.
Sure. Basically, in the host program, we have a physician's assistant on site who can assist with that directly. But I'll tell you kind of what my practice is. If someone has chronic pain from a legitimate medical condition and they legitimately need pain medication, then pain medication should be prescribed. However, there are some techniques that you can do to minimize the risk for someone using pain medication who has a substance use disorder. First of all would be a stepwise approach to managing pain. and this would be done in conjunction with a primary care specialist, or in some cases in conjunction with a pain management specialist. But starting with the medicine that has the least potential for harm in terms of addiction or diversion, what might be, for example, to start with a non-steroidal anti-inflammatory type agent similar to ibuprofen. Often that can't help with chronic pain. Then it would be looking at the safe use of a narcotic pain-relieving medication, and some of the things that can be done to sort of help monitor for risks of abuse would, of course, be ongoing counseling about that risk. Might be prescribing medications in small quantities more frequently. It might be, and this would require a pain management specialist, the use of a long-acting pain medication such as methadone is now being used by chronic pain specialists. And while methadone can be abused, it doesn't provide the immediate that others do. In addition, a medication used for substance abuse treatment for opiate addiction, buprenorphine, is another medication that's sometimes utilized by pain specialists. And also used in addiction treatment, and actually I currently do use that for management of a few select individuals with opiate addiction but without chronic pain. And finally, use of adjunctive pain resources such as acupuncture, acupressure, skillful use of herbal medicine. In terms of medical cannabis, a controversial area. Certainly in California, there's a huge amount of controversy about what conditions are appropriate for the use of medical marijuana. There are certainly numerous individuals who use cannabis as a pain management tool. And I actually have a couple on my caseload who are supplementing their pain medication with medical cannabis, who are being monitored in terms of their self-report, at least, of how they're utilizing it and when they're using it. So sometimes even medical cannabis might be an acceptable adjunctive treatment for select individuals. And then, referral to pain management clinics and pain specialists for doing what they do would be another service that could be offered by the mental health service.
Great.
Does that get to the heart of the question?
Yeah, I think that's an appreciated response. Yeah, that was pretty comprehensive, the suggestions and the strategies that can be used. I'm also wondering if, and the callers just kind of sent me a message saying, yes, that was a great answer, so thank you. There was also an observation at some point during the presentation about the challenges between inpatient and outpatient treatment sometimes not being as integrated as would seem helpful. And that's both in terms of the philosophy sometimes that's evident in inpatient settings as opposed to outpatient settings, and also looking at the concerns around how to engage someone in services, having integrated kind of approaches so that when someone's being discharged that there's engagement to get them into outpatient services, or at least offering them outpatient services. So I'm wondering if you have any comments about those, observations.
Yeah, I sure do. And it's an ongoing challenge. My experience is that I have some hospitals which are much more collaborative than others. One of the ways, in certain hospitals, if one of the consumers that I'm treating ends up in the hospital, that hospital will contact us and notify us that our client is there. And one of the things that can happen is there can be a phone consultation with the inpatient psychiatrist. Also, we have case managers who can not only have telephone contact, say with the inpatient social worker, but also go and meet with the consumer while they're in the hospital to facilitate linkage. That process can sometimes begin before a person is referred to us. Well, let me backtrack. An individual might be referred to us through the centralized county access program prior to being released from the hospital, in which case we can send the case manager out to begin meeting with them. This is particularly something that can happen more easily in longer-term subacute settings, whereas acute inpatient settings, often the stays are very, very short. But even so, we try to meet with the consumer while they're in the hospital. I let them know, what type of services we offer, and attempt to set up appointments and assist them in getting to appointments. In addition, the case managers in our early engagement team, and right now I'm talking about our SIL program, they're assigned smaller caseloads so they can go out and engage these consumers who are referred to us to try to involve them in some type of treatment with our program. And that's sometimes challenging and sometimes takes months before a person might be ready actually to come in and accept services from us. And sometimes it really involves needing to find out what that individual's needs are, and by helping them with that need, they may be more amenable to treatment. There are systems issues sometimes, however, which impede the type of ideal collaboration that I'm talking about, and that is an ongoing issue, particularly with some of the acute care facilities where medication changes and other treatment changes are made without consultation with the outpatient treatment team. And that's an ongoing issue. In Alameda County, we have a monthly meeting between lead psychiatrists from all the programs, and that's something that we've talked about in terms of our county mental health hospital. And actually improvements have been made so that at a minimum communication with the case manager occurs, and in some cases contact with the inpatient psychiatrist happens either as a result of that inpatient psychiatrist calling me or me calling that individual, but it's inconsistent. So we have focused on facilitation of information flow and seeing some improvements in getting discharge documents sent to the clinic so that at least that information is available to me and the case management team prior to the individual showing up for an appointment. So those are some thoughts I had to share. It's an ongoing systems issue, and it's something that is not really consistent and doesn't work perfectly by any stretch of the imagination.
Well, thank you, Dr. Brown. I'm not seeing any other questions come in right now. I do want to remind folks that we will have this webcast has been recorded, and we will be posting it on the CIMH website under webcasts. So I will send the link out to everybody who's participating this morning. And as well, you should have already received the presentation was emailed out to everybody on Thursday. So any other thoughts about how folks might be able to promote IDD, not promote, that might be the wrong word, but promote the integrated approach to dual diagnosis and to meeting the needs of clients in the community? Dr. Brown, any thoughts?
Thoughts about that? Well, I think that one of the main issues, I think, is to work closely with the leadership of local mental health or behavioral service systems. in order to help provide them with the resources necessary to understand why this is an important issue and how services can be developed. In doing some preparation for this, and actually I don't have the reference to that, I kind of ran across it and I couldn't find it when I was looking for it. But in Ohio, which is an early adapter of the IDDT model statewide, they've actually done some research and looking at costs, and they found that there are, in fact, cost savings that the state of Ohio has been able to achieve as a result of implementing the IDDT model. And so if quality and patient care outcomes isn't enough, there may be some evidence out there for how that this may, in the long run, result in some cost savings as we get hopefully reduce inpatient utilization and also improve clinical outcomes. So
okay.
That's helpful.
Yeah, and then we did have one last question about, and I'm not recalling when you referenced this in the presentation, so my apologies, but how did you get the psychiatrist meeting going?
Oh, well, this is a meeting that was developed by the Alameda County Behavioral Health Medical Director. So we have a mental health director who in our county is Dr. Mary Thomas, and we also have a county medical director who currently is Dr. Aaron Chapman, previously was Dr. Richard Singer. The Psychiatric Practices Committee was organized by Dr. Singer during his tenure there, and so it's something that was organized actually before I even came into the system. So it was developed as a result of leadership at the mental health department level, recognizing that there would be benefits in having psychiatrists come together to look at systems issues, to problem solve, share experiences, and we also function as a to establish county psychotropic medication formulary. So I can't take any credit for organizing it. I'm just glad it's there. It's a very helpful meeting, and that may be something to suggest as a way, maybe not specifically of improving integrated care, but to see if there could be some way of organizing something like that on a regular basis, whether it be monthly or less frequently or whatever. But we've found it very helpful in Alameda County.
Great, great, and the person really appreciates your response. And then finally, we did have one quick question from someone in Calaveras County who's wondering about the privacy issues between consumers when you're having groups and how people's privacy is assured.
Well, it's sort of what happens in Vegas stays in Vegas. First of all, there needs to be consent on the part of an individual consumer to participate in group treatment. Yeah, I'm willing. Yeah, I understand that. I'm going to be telling my business people. Group leadership should provide rules and regulations. Not rules and regulations, but basic rules of conduct. But by the very nature of group work, some confidentiality is lost. And so among the things that a skilled group facilitator might do is there may be some issues which are very sensitive to talk about in group, and for that individual safety might say, let's maybe talk one-on-one after group about that particular issue or before you go into any more detail. So that was one thing that could happen. But basically when people agree to treatment in group-based work, they are agreeing to share confidential information about themselves, and that's actually one of the reasons that group work can be helpful.
Great. And then there's a follow-up question about how consumer contact time is split between a group and individualized wraparound time, and I'm not sure if that's more of a how do you document or what have you, but do you have any response to that question?
In California, in terms of documenting group work, each individual attending the group needs to have an individualized progress note. So you can't write just one single group note. You could include in your documentation a sort of an overall comment about the group, but then you have to specifically address issues, participation, etc. for that individual. There are, of course, as there is with everything, there are rules and regulations that have to be followed in terms of documenting group work, in terms of getting reimbursement, etc., which don't necessarily facilitate the development of groups in my experience, but there are workarounds that can happen. That's how what happens to an individual is documented. And I hope that goes to the question or addresses the question.
Yeah, I think it does. And then I would like to just offer a comment and ask you if it seems like a correct interpretation. But when we were mentioning before about the role of the mental health boards and the fact that when you're doing an evaluation of a program, you're not necessarily evaluating the clinical practice of staff necessarily. However, because of your reference to the types of training that would be helpful for staff to receive, I would imagine that mental health board members could definitely integrate those types of questions into any kind of a site visit in terms of asking staff what type of training do you have access to, and are there types of training that you feel are important to have, or, you know what I mean? Because mental health board members might be able to advocate for, you know, what have you, increased funding, or looking at a way that training dollars can be more effectively used so that periodic training in the most important practices is available to staff to be able to support the program. So
absolutely agree 100%. And in doing a program evaluation, commonly program evaluators might speak with individual staff members, might even be able to speak with consumers or family members. We've had certainly evaluations where that sort of thing happened, and those would be among the questions that you could ask. What training have you had in motivational interviewing? What training, what supervision do you get around incorporating integrated counseling skills and stuff like that? Because you want to get an idea of what happens from an administrator's perspective or a supervisor's perspective, and that in some cases may not be completely the same outlook that an individual staff member or an individual clinician might have. So I think, yes, while you're not directly, say, observing an individual in their interactions with a consumer, you can ask them about basic Fidelity elements and compare their responses to, say, what the supervisor says, administrator says about it.
Great. And then we have, well, let's call it the final question of the day, and it's one of my favorites because I think it's such a critical question to be thought about, is whether or not, and you're aware of any any inpatient settings using IDDT. In your experience, maybe within your county or what have you, but when we're looking at having that integrated approach, whether or not people are actually using IDDT in inpatient settings is going to be, take us much further along the path of knowing whether or not we already have a ready-made, good working relationship that we're going to be able to have around integrated care.
Yeah, that's a good question. And I don't know of any inpatient services that are specifically using IDDT or IDDT elements. There have been some of our local hospitals who at times have had co-occurring treatment disorders units. Some of those have gone by the wayside as inpatient beds and consolidation has taken place. So that would certainly be a challenge if mental health boards wanted to take that on, would be to provide motivation for inpatient programs to begin looking at their own co-occurring disorders practices and integrating as many of the IDDT concepts and elements as possible. I think that would be a terrific project if someone wanted to take that on. In Alameda County, there's an odd division, the county hospital system and the behavioral health system, while under the administration of the Director of Public Health, are actually separate and actually contract for services. So there is not a direct, the local county mental health director does not have direct control over the local county mental health hospital. And that issue becomes even more of an issue when there are private community-based hospitals, which are basically also contract facilities. So, you know, it becomes much more of a political issue in terms of how to go about that. So that might well be something that mental health boards could be helpful with.
Great. So Dr. Brown, I think I'd like to thank you, I know I'd like to thank you for a wonderful presentation. We've got a lot of great feedback through the use of our question and chat boxes on the value of what you presented today. And specifically in terms of when you were looking at how mental health boards can really take this on and think about how they can integrate that into whether it's their site evaluations or their just growing education about how their systems are set up with different types of services to make sure people are getting integrated care. So thank you very much. I want to remind participants that Dr. Brown's email address is floyd@bonitahouse.org. And then I also want to remind folks that the webcasts that we do are recorded, and you'll find them on the CIMH website within a week of our webcast, underneath learning, and then underneath online learning and webcasts. So that's where they're posted on our CIMH website, but I will be sending the link out to all participants. So Dr. Brown, any closing remarks or anything that you'd like to say as we wrap up?
I'd like to say I appreciate the opportunity to do this presentation, and thanks everybody for the good and very cogent questions. And I hope everybody enjoys the rest of their Saturday.
And as we close out of the webinar now, I want to remind folks that there's a pop-up survey that will take just a few minutes to answer, making sure that we're able to assess whether or not we met our learning objectives. So we ask you to complete that. Okay, well, thank you very much, Dr. Brown, and thank you to everybody from throughout the state of California from your mental health boards who's participated. I think we had 16 or 17 different counties participating this morning. So as Dr. Brown said, have a great rest of your Saturday, and we will see you next time. Okay, take care.